Hi, I'm Dr. Jack West, medical oncologist at City of Hope Comprehensive Cancer Center in Los Angeles. This is West Wind, a podcast focusing on the intersection of cancer care, emerging technology issues in medicine, and healthcare policy. You can find information about subscribing at beaconmedic.com or wherever you find your podcast content. Please leave a review, especially if you like this, and we'd also love to get your feedback at westwindpodcast@gmail.com. I'm happy to be here today with Dr. Giorgio Scagliotti, who is professor of medical oncology and former chief of the Department of Oncology at the University of Turin in Turin, Italy, and currently a member of the administrative board there, and the chief of medical oncology at St. Luigi Hospital Orbisano in Turin. He's also the president of IASLC. We've seen in the last decade or so a remarkable change in how lung cancer is treated. What do you consider to be the key milestones and seminal concepts that have changed how we practice from histology, imaging, whatever? What do you see are the most important issues that have been the quantum leaps in thoracic oncology?
Well, I believe that over the last, let me say, 20 years, in the field of thoracic oncology, not only in the field of thoracic oncology, we saw several waves of innovation. The first one, at least in my mind, was the full sequencing of the human genome. And obviously, the full sequencing of the human genome was followed by the sequencing of the lung cancer that came in 2006, 2007. The full exome sequencing of the first patients with lung cancer. The second big wave of innovation was represented by the implementation into the clinical practice of targeted therapies. For us, it was really a cornerstone, the opportunity to treat patients with one pill and to see suddenly in less than 3 weeks the tumor vanishing away. I'm referring to the EGFR mutation and later on to the ALK translocated patients. Subsequently, and over the last 5 years, another wave of innovation came to our treatment opportunities that is represented by the immunotherapy approach. So the immunotherapy, I can easily tell you that I was pretty skeptical at the beginning, but the data and the facts were convincing me that at least for a subgroup of our patients, immunotherapy is something that is changing the natural history of the disease. But I see immunotherapy as I saw targeted therapies in the context of a broader precision medicine approach. I do not believe that immunotherapy in the future will be a viable option for every one of our patients. What we are still missing is an ideal biomarker, or let's say a diagnostic algorithm that will be able to predict who is getting a huge benefit from immunotherapy. As we did before for targeted therapies, because you remember better than me that at the beginning of the century we were discussing about immunohistochemistry, FISH, or EGFR mutation for EGFR TKI agents. But the speed of the research that was progressively increasing over the last few years is making me positive about the opportunity to find in the near future the right set of biomarkers. Because obviously, differently from the past, and I'm speaking mainly for Europe, I'm not speaking for US, but I believe that the same story sooner or later will come also for US. The financial toxicity of these agents is pretty huge. And you have to consider that in Europe, as well as in the United States, the average age of diagnosis is 70. So they are already retired people in the vast majority. with limited financial resources. And consequently, you need, at least in my view, for any new treatment, you need to provide really value. When you are asking for expensive treatments, but you need to be sure that you are improving quantitatively, not only qualitatively, but also quantitatively, the survival of each individual patient.
So for these agents that are now well over $10,000, even $15,000 a month, and they're different in Europe, but still quite challengingly expensive, does that mean that the threshold needs to be higher to achieve value than the cost of giving a conventional chemotherapy that costs $2,000 or $3,000?
Yeah, I'm saying that when there is no question that single agent pembrolizumab that is already approved for patients who are positive for more than 50%, the likelihood to get a response is definitively higher compared to other patients. Obviously, the tumor shrinkage is not seen in, let's say, universally in the vast majority or in every individual patient, right. But the survival data are pretty compelling.
Yes.
On the other side, when you are trying to sell the idea that these expensive drugs should be offered to everyone, independently from any type of expression. Well, when you are looking to the data, it is true that they are impacting in terms of hazard ratio in some way, but the impact is still clinically marginal. So when you are moving the hazard ratio from 1 to 0.72, well, it is true that the study is statistically positive. I'm asking myself, because sometimes the clinical practice is different from science, I'm asking myself if this huge amount of money is worth to be spent for each individual patient when you are standing in front of a 75, 78 years old patient that has a PS of 0, let's say 1.5, that is getting close to 2 with several comorbid conditions. I'm asking myself if a couple of months of survival improvement is worth to be achieved.
The field of thoracic oncology, or a lot of cancer care, has become increasingly complex, and we have more expensive agents. Is the disparity of what is available in academic centers versus further out in the community in terms of level of expert care or up-to-date, the latest, as well as the therapies, because of either what is known about or the cost, is that issue of disparity becoming a bigger problem that is a bottleneck essentially in how patients are going to do?
It's not only, well, at least in the EU, it's not only a matter of social disparities. It's mainly the way in which you are getting diagnosed with lung cancer. Obviously, I'm referring to the disparity between the academic center and the centers and the community centers, because sometimes they don't have any in-house facility for molecular testing, so they need to send tissue samples outside. And consequently, the waiting time to get back the molecular testing results sometimes is exceeding the 3 weeks. And they are starting delivering chemotherapy, and suddenly they will discover that one patient has an EGFR mutation. Then they are calling us, say what I should do. And in the meantime, they did a CT scan, and the tumor is shrinking under chemotherapy, and they are in the middle of nowhere because they don't know what they should do. And it's also difficult with a tumor that is getting a benefit from chemotherapy to switch to targeted therapies. But that with targeted therapies, the clinical benefit will be definitively superior. In addition to that, I believe that the level of education of the physician in the community is still something that we need to work on, and that is where ISLC is coming in. But we need to to tailor specific educational program to keep the level of education relatively low, relatively basic, let me say, because we need to increase the amount of patients not getting the EGFR testing, but let's say to get the minimal set of molecular testing that is needed to guide a treatment decision in these days. And that is the main disparity that I see between patients who are referred to academic centers, those who are diagnosed in the community.
One of the concepts that in the US we're starting to try to work on as a way to address the gulf of what is available, at least in terms of the ability to keep up with all these developments, is telemedicine and consults between the subspecialists and general oncology offices, or potentially directly to patients. It's still struggling to get off the ground in the US. Is there anything like that happening in Europe, or because you have pretty centralized systems with the experts concentrated in a few places, or is that still far away?
Well, we are trying to implement in the digital world. Everything is becoming pretty easy compared to what we were used to do 10 years ago. You was already doing a lot of things 10 years ago. But now we are trying to transfer our multidisciplinary tumor board on a teleconference facility. And what we are doing, the physicians in the community, they are uploading the slides the day before. They are sending a short summary of the clinical case. And we are trying to discuss over the teleconference facility the most complicated cases, just to avoid this huge problem that is traveling of the patients from the periphery to the center. You know, I'm working in a region that everything is pretty close. It's not like the United States, because everything is, let's say, a couple of hours away. That for you in the United States is a short drive. But for us, it's already something that is pretty difficult. And we are still piloting the idea, because obviously to upload the slides and to upload the CT the day before, it's, you need large space, large bioinformatics space, because obviously to upload the CT scan, we are trying to do few cases at the beginning, but just to facilitate the interaction between the community and our multidisciplinary clinic.
Finally, one of the important studies that you led looked at neoadjuvant preoperative chemotherapy and was frankly quite encouraging, at least for the higher risk patients. That has kind of been left behind just due to historical accident, that the postoperative adjuvant trials came positive, and that's kind of where things went. However, now there's growing interest, it seems, in neoadjuvant treatments in clinical trials with immunotherapy, potentially targeted therapies, and maybe integrating this with chemo as well. Is neoadjuvant treatment in lung cancer and maybe other cancers poised for a resurgence?
I strongly hope that you are absolutely right, because I'm a truly believer of the neoadjuvant approach, especially in the era of targeted therapies and immunotherapy. Obviously, we need to set up the stage, because the usual parameters, including also the measured pathological response or the complete response that we were used to assess with chemotherapy, probably we need to redesign the frame in the context of targeted therapies and immunotherapy. And there are, in our organization, in our ISSC world, there is a pathology committee that is working on a sort of blueprint project to establish how to assess across the globe the measured pathological response, how to find potential surrogate markers for long-term survival. And we would like to sit down with pharma and with the major cooperative groups to see if there is an opportunity to follow the same variables and how to identify the ideal cutoff to separate the high-risk patient from the low-risk patients. This is a kind of scientific exercise that is not leading to any change in the short period of time, but the opportunity to revisit the neoadjuvant approach combined with the increasing number of patients who are detected through screening studies. It's a unique opportunity.
Well, another thing that's unique is this window of opportunity
Absolutely,
of
yes.
being able to do this biological intervention
Absolutely,
and
yes.
then get the tissue back to see what you got.
Because in addition to that, you can also tailor or change or modulate the post-surgical therapies.
Right.
And that is another value of the molecular correlative studies that you can do a baseline at the time of surgery.
So you have a unique opportunity for a level of feedback we've never had before.
Yeah, absolutely, yes. And that is something that in the near future we need to explore even more than what we did with chemotherapy. We need to convince thoracic surgeons that a couple of cycles of immunotherapy before surgery is not compromising anyhow the success rate of surgical resection. But that is another story. And I would like to leave you with one of my scientific mantra that I have in mind. I truly believe that every one of us should learn how to use more frequently systemic therapies in the setting of early stages, and how to use, at the best, local therapies in the management of stage 4 non-small cell lung cancer.
Excellent. Well, thank you so much for joining us.
Thank you for inviting me.
Thanks so much for joining me today for this West Wind podcast. We hope you'll be interested enough to subscribe either by checking out the options at beaconmedic.com or looking for West Wind Podcast on iTunes or wherever you find your audio content. Please take the time to submit a review, and we'd also welcome your feedback at westwindpodcast@gmail.com. Until next time, this is Dr. Jack West. Thanks for listening.